Hello, hello. We know that we have the honor of being the panel that stands between you and lunch, but we're not going to speed up this talk because it's very important and one that's near and dear to our hearts. I'm Brenda Shipley with the Sequoia Project, and I am happy to introduce our Consumer Voices panel. I do need the clicker, if we have that over there. Okay. Anyway, joining us is Shamekka Marty. She joins us from the Bay Area. Oh, thank you.
Sure.
She joins us from the Bay Area, and Shamekka is a participant in our Consumer Voices Workgroup. She is a fearless patient, caregiver, and courageous patient advocate. We also have Grace Cordovano, who's joining us from the New York area. And Grace is the co-chair of the Consumer Voices Workgroup, and she is a board-certified patient advocate. And also joining us is Anna McCollister, and Anna is joining us from the DC area, and she will be leading our Consumer Engagement Strategy Workgroup. She has worked in healthcare technology and innovations from the patient perspective, and also serves on high tech. So thank you, panel. What we thought we'd do is get started with Shamekka. During the Consumer Voices Workgroup, you shared so many compelling stories and talked a lot about your experiences accessing, using, and sharing your patient records. And in this audience sit some people who have the wherewithal to create change and to make things better. And I think they'd be interested in hearing some of your stories. So if you could share, that'd be wonderful.
Yes. My name is Shamekka Marty, and as you can see from the pictures, this is my family. I've been dealing with patient caregiving since I was 10 years old. My mother had lupus. She sadly passed away at age 44, about 22 years ago. And then also my Nana on the left, she had severe rheumatoid arthritis, and she was bedridden for the last 20 years of her life. So it was kind of rough. It was me and my brother, and I had to grow up really fast, learning about what they needed, and then also learning how to drive at age 14 so I can take them to their doctor's appointments. So my experience has been forever for me. And then 13 years ago, I was diagnosed with lupus as well. I'm glad to say that navigating the healthcare system is very hard. I am glad that because of lupus, earlier this year I did receive a kidney transplant, so I am here to speak with you today. So I'm very blessed, and I want to keep that blessing going and letting people know the things that people have to go through. Just being sick is a full-time job, and if you don't do it right, things could go out of control. Just missing something, not speaking up, and I was the voice for the voiceless. So that's why it was very passionate for me to give as much as I could information-wise to you guys, and forever I will be indebted to just making sure that other patients are heard, because there's just so many other people out there that need help and guidance.
Thank you, Shamekka. Could you share a couple of the stories I think that resonated for us were around, like, what would happen if you would bring like your uncle to the emergency room, and yet family members, and could you share that particular story?
My uncle also, I am still his caregiver. He has HIV, and even from afar, because he still lives in New Jersey, anything that has to do with him medically has to go through me. So when I was there, I would go to the doctor's offices with him, but most importantly, when I would go to the emergency room, just trying to get information, and from his other doctors, if they were not in the same network, it was very hard to get the two different networks to talk, or the two different doctors to talk, and make sure that they're not missing anything. One time they gave him medication that was listed on his chart, but on a different chart, it said that that was an allergic reaction and caused a lot of things. And if I wasn't there, if I wasn't being present because he's knocked out, that could have been really, really bad, really quick. getting his information from one doctor to another or his medical test and chasing that down. Hey, he went on Friday, now it's Wednesday, still have not heard back. We need to know exactly what's going on. In New Jersey, and I'm not sure if it happens here, the particular hospital that he goes to, they assign you a code. If you're not present there to receive that code, you cannot get information. And that's the way that they lock things down. And I'm like, he came in, he was unconscious. It should be noted in his chart that I am his medical proxy. And trying to jump through hoops and seeing who I can talk to and calling this doctor and making my own Google Doc to be able to share to other people just in case if I can't make it, I'm in a meeting, things like that. And I don't think when we take into consideration other situations like this, do we implement that for anything that we're making for applications to help the patient? That's why we need to engage other patient advocates and other people who experience it on an everyday basis to give input to help with these applications that are being developed.
Thank you so much, Shamekka. Your family is so lucky to have you.
Thank you. I'm lucky to have them.
Yeah. Thank you. So Grace, you heard some of Shamekka's stories earlier, also as co-chair of the Consumer Voices Workgroup. Give us your reactions, your perspectives, and maybe your thoughts on priorities going forward from a patient-centric interoperability standpoint.
First of all, working with this group of patients and with Shauna and this entire team brought me so much joy. I am obsessed with patient stories and family stories because the more you listen, the more you learn, and the more strategies and insights it gives us on how we implement, how we solve for really difficult things. So we've been talking about TEFCA and access, 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 access. Did you hear Shamekka say access at any point? No, because Shamekka's busy doing work, because it takes work to be a patient. It's called patient administrative burden, the work that people, patients, families, care partners, caregivers, advocates need to do to get the care they need. Something that I really haven't heard mentioned, which is causing a major impact at point of care and outside of point of care, is staff shortages. I can see the direct impact. Tasks that and information that would normally be relayed at point of care, it's not happening now. No one's calling. You can't get a call back. There's no human. You're turned to a chatbot. Portal messages are not being answered. And this isn't just about access for access sake, like we're having fun looking at it. This is access because lives are at stake. So I think even from a brand and marketing thing, what I would say is, this individual access doesn't have that sense of urgency. And as I've been reflecting and listening, Marianne, I so appreciate what you said. We need must-do energy, so I'm bringing it back to that. We need big energy around this. And Mickey gave such a great overview, and I know all of you are working so hard, and that's why this work brings me joy, because I see incremental progress and change. The power of public-private patient partnership can't be underestimated. And I think as I sit here before you and listening to Shamekka just share her perspectives, what if we looked at IAS just a little bit differently? It's not all just for access. Mickey said, what's that seventh use case? What if it was emergency lives at stake? What if it's the mom whose child was sent home to die and she needs those records to get into a clinical trial? What if it's your spouse who has an undiagnosed rare disease and needs to get into that NIH program and needs all their records yesterday? What if it's your mother that needs a drug and the insurance company denied it and you need to write a letter of medical necessity and appeal that insurance denial? So the patients that I work with need access now, and it's not the same access we're talking about. So I'm just going to hone in on that piece. What if we thought about access slightly differently in two categories? Your run-of-the-mill access, lives that are at stake access.
Love that. Love that. Thank you, Grace. Anna, do you want to chime in now a little bit on, so far you've heard Shamekka's story and you've heard about Grace's passion. Talk to us a little bit about your vision for the next stage of this work.
Well, to give you a little bit of context as to how I got into this, I used to do other things. I started in economic policy, foreign policy, because of personal reasons. I switched gears, got into healthcare, and I ran global communications for two of the large global communications public affairs agencies. And over time got more and more frustrated around research and stagnation with research and the over-reliance on blood-based biomarkers and randomized controlled trials. So I came into this from the nerdy perspective of how can we use all of the data that's coming online to generate real-world evidence that actually represents the complexity of life's disease. So, 13 years ago, I co-founded a company to do big data analytics through a visual interface that allowed you to develop and begin to build out digital biomarkers. Over time, as I gained a little bit of knowledge and insight into health IT, I began to realize that a lot of the issues that I was experiencing as a patient, and many of the issues that I was experiencing with my diabetes devices, as well as access to clinical data, were solvable. These were very fixable problems, just nobody really had bothered to fix them yet. And one of the things that was really lacking, that I think is still lacking in many respects, even 13 years later after working as an advocate and as a professional in the health IT world, is that lack of urgency. It's so difficult to keep that lack of urgency going when you're trying to deal with the bureaucracy of either your company or trying to figure out new government regs or with hospital systems. There are all of these reasons not to push, and it's very difficult to maintain that sense of urgency until you have it. And I think it's the sense of urgency that when it comes to engaging consumers, that's the thing that's difficult to harness unless somebody has actually been there and they've experienced what it's like to need records, to need information now, either for themselves or for their loved ones, and to not be able to get it. And the vast majority of people, my friends, my family members, aren't walking around thinking about how can I access my clinical data. They may get into their portal from time to time, but when it comes to something critical and something important, they want access to that data. They need to find that data at that point. But at that point, it's too late to begin engaging and to start pushing for policy. So as it relates to engaging consumers, that's one of the challenges that we have to find, that we have to face, is identifying individuals who have experienced that sense of frustration and fear, and in many cases, the calamity that comes with not being able to access data, be able to harness their voices, people like Grace and Shamekka, and many other friends that I've made over the years in working through this. How do you harness those voices and help them serve as surrogates for all of the other people who one day will have these same experiences, but just haven't been forced to encounter them yet. The reality is that's going to be everyone in this room at some point in time, whether it's for you or for your family member, et cetera. For people like me, and for Shamekka, who live with chronic disease, it's a regular occurrence. I mean, I have a slide that talks about my diabetes, my type 1 diabetes regimen, and in addition to type 1, I have all the complications from diabetes. So I have eye disease, nerve disease, kidney disease. I take 13 different meds. I use 4 prescription medical devices, about 5 other non-prescription medical devices, all of which, and I get lab work done at least every 3 months. There are about 63 different values that I focus on specifically to help me understand my chronic diseases. Any one of those things can be challenging, but when you get into the cumulative burden of managing all of that, even if it takes 5 minutes to sign into your portal, well, 5 minutes times all of the other things gets challenging. Of the 13 medications I take, prior authorization for 3 of them is a really, really big burden. Getting to the drugstore, finding out if they have the medication, finding out if there's an issue or a shortage. All of that, when you take it from a cumulative perspective, really sucks time drastically. And it does it, the time is substantial, but it's also, there's a substantial psychological impact on what it means to spend that much of your life just focusing on the administrative burden of living with disease. And those are the kinds of things that the people in this room can help fix. I mean, I can talk about it. You know, I've done enough coding in my life, and after I've done 2 health technology startups and been around and helped start a patient hacker movement in the type 1 diabetes space. I've done enough coding to know that like that's not the skill set that I bring to the table. But the people in this room have the ability to actually change some of this and to make it happen and to make it possible. So when we think about what are we going to be doing with the consumer engagement workshop or work group, I'm really excited because I've led different types of consumer efforts to get groups of patients and parents to comment on guidance documents or proposed rules with ONC as well as FDA and HHS more broadly. And that's great and it's important. And I've seen the efforts that I've been involved with actually make real change when it comes to policy. But policy can only get you so far. It's the people in this room that really have the chance to not just look at the letter of the policy, but to push beyond and say, how can we engage with individuals who, for one reason or another, have been forced to care about health data and get their perspectives to help us get our organizations to move more quickly and more effectively to make this stuff happen. Because it will impact you, it will impact your family. And that sense of urgency will fall at a time when trying to access the various portals, trying to coordinate different apps is not going to work well with what you need to be focused on at that point in time. So I'm excited about what we can do through the work group, and you know, we're just beginning, just starting to dig in and explore, but I'm really hopeful that I can work with each of you and find ways to really make this stuff move forward quickly.
Super, Anna. And Anna, you won't be starting with a blank slate because of the work that Grace has done and Shamekka did with Consumer Voices. Grace, do you want to add a little bit, you know, for those that may not have read the report of findings, a little bit more about the types of information that we receive from our consumer focus group and how that resulted in some priority actions that Anna's group will now be taking a look at as a starting point.
Mm-hmm. You know, I'm going to take a step back to when the information blocking rules were implemented and journalists got a hold of it and said, oh, patients have access to their records and the doctors are too afraid. No, don't look at it. You can't handle it. Let me tell you, this group, they handled it and then did more than that. And they expressed what they want, when they want it. They need it all. The fact that there's a scary diagnosis doesn't take away from the burden that Anna was describing or that Shamekka was describing. The work still needs to get done. And for anyone who's still in the camp of, we really shouldn't give patients their health information because, you know, they're too illiterate, too stupid, too non-compliant, too non-adherent, drug-seeking, lazy, all of those stigmatizing words, that results cause harm, then we should stop sending these exorbitant bills to people's homes because let me tell you, that causes harm. I've watched patients contemplate divorce, contemplate fleeing the country, contemplate bankruptcy, contemplate suicide. Do we stop sending bills? No. We have financial support services to support patients, and I see a big opportunity with the presence in the room. Now that there is access, we need to help people be able to do the work that they need to do. I want to touch on something you said because we're implying that access is for people in this room, adults. I was a child navigating US healthcare. English is my second language. And I applaud you, Shamekka, because it is not easy as a child to try to navigate US healthcare for adults. So I work with immigrant populations, and I have a very special place in my heart because I was that kid one day that had to figure out and was using an encyclopedia and a dictionary trying to figure out what's on the prescription bottles for loved ones, family, neighbors, and parishioners. Let's not assume that it's just adults accessing health information. What if we're helping immigrant populations and the younger generations, the teenagers, the children who may be the most digitally savvy, who may have the most English proficiency, and they need those records? Let's not forget about looking at it through that lens too. Going back to Marianne, we must do this. So even last night, as I sat at a beautiful dinner that was hosted here, I can feel feelings of anger and disappointment and being disheartened and hearing so many people keep repeating, we don't expect IAS to be responded to on day one, which means I'm going back to the patients that I serve and I say, there's a utility here, there is a solution, but we're not ready to deploy it yet. I'm sorry, your child may need to die. Your husband may not get into that trial. I'm sorry, you need to go to 30 patient portals and do it manually. No one has time for that. So I'm asking again, how can we not say we're not going to respond on day one? How do we find to say, what can we do on day one? Maybe it's emergency cases. Maybe it's these cases where there's children and teenagers that need to get access. Maybe it's for clinical trials, which we know that is a disaster and not enough patients are enrolling. You can't enroll in a trial if you don't have your medical records, bottom line. So let's find collaboratively something that we can start somewhere and remove this. We're not going to respond on day one. I can't let that continue.
Thank you, Grace. Appreciate that. Shamekka, hearing from Grace and Anna and reflecting on your work with the Consumer Voices Workgroup, were you surprised that there was an organization that was looking into this? Give us some of your initial thoughts on, that developed over time of, working with other advocates on this.
Because I've been involved in a lot of focus groups, this was the first one that focused purely on patient caregiving. And yes, I was surprised, and I was also elated that finally something like this was coming about. And not just for me being a child doing it, but as you had stated, English is not your first language. I live in the Bay Area, extremely diverse. Do you know how many times I go into doctor's offices and there's an immigrant lady who is about 70 years old, refuses to learn anything else. She just wants to sit there, and she has her grandchild with her. And her grandchild is just like, I'm gonna translate, but I have no idea what I'm translating. And I sit there and I'm like, I can relate to that in a particular way where there wasn't a language barrier. It was just, they don't know what's going on. And I'm old, so I went into Encyclopedia Britannica when I was younger, and I'm looking things up because there wasn't an internet then, and just trying to figure things out. And I'm like, great, you know what? What I went through is useful. There is a reason why I went through this, and that's why I'm passionate about doing it. I love your passion in doing it because it comes from a perspective that you have done it growing up as well, and now you have this as a full-time job. And now that we have the floor and we have the mic, we want to share with you the reasons why this needs to change. And I'm glad that there was something documented very well and put out there so that people can refer back. We're speaking about it, but you can refer back to exactly what other people who were on the group had to say as well. And there were a lot of other people that were older, that were trying to navigate it, and it was more so a technology thing. It's like, we don't have the doctors sit down with you. When you go to the doctor's office, they give you a piece of paper, here's your new patient portal code, and make your password, and if you're not tech savvy, it's like, what do I do with this? And half the time, they don't even sign up for it. So what are we doing about that? So I'm very, very happy that this exists.
Yeah. One of the other things that came out of one of the conversations in this work group was about usability of what you could access. And it reminds me of the data usability work that we're also doing in Interoperability Matters. And it's one thing to get access to your information, but if it is written with medical lingo, you can't understand it, then of what purpose is getting that information? And I think that, could you speak a little bit to that? It came up in the group, I think, about the usability of the information shared.
I can speak to that just on a daily basis. I get my labs done every week because of the kidney transplant, so they want to track it for the year. And I look at it, of course, diligently because I have the app on my phone before the doctor even thinks about calling me. Of course, the first thing you're going to do is like, I want to read it. And I'm like, okay, I don't know what this means. I'll copy, paste it, put it in Google, and it'll explain, oh, okay, if your range is between this and this. Certain things are very technical and very detailed, and I'm like, I don't know what that means. I'll wait for the doctor, even though I've looked it up, or I can understand it. But the doctor is seeing so many patients, and you're at the mercy of them to call you back. Otherwise, you're sitting there with anxiety. Is this a good thing? Is this a bad thing? What can I do about this? Or they'll say, you can't read this until your doctor reads it, then that's the biggest thing where you're just now really anxiety ridden. But I think the best experience that I had was with the Mayo Clinic. I went to the Mayo Clinic. I was trying to get on multiple lists for kidney transplant. The Mayo Clinic, within 5 minutes, somebody read it. I don't know if it's because it's properly staffed, and that's probably why it's one of the best facilities in the United States, but they were quick about it. I am affiliated with Stanford, John Muir, and several different hospitals, and it takes a lot of time. But I don't think they're thinking about that. They're not worrying about the patient. Like she said, you know, you call in and you're just, all right, well, we'll get to you when we get to you. Oh, the doctor's not in, he's on vacation. He's allowed to take a vacation, but I went to go get a test. Is there someone else that can go ahead and help me? And just trying to navigate it. Or not a lot of people have other friends that are doctors and nurses. My best friend is a nurse. If I'm really, really, really in a rut, I'm like, what does this mean? And she'll tell me. Not everybody has that. So think about it that way. I mean, it's very hard because we want to understand, we want to get that information quickly. And sometimes the hardest thing is finding out a diagnosis and validating, you know what, I'm not crazy. I had all these symptoms and there's something there, but I really can't tell what it is, or especially when you're reading radiology things. This is a presence of this seemed like it doesn't make too much sense to the regular person. So just having that quickness and someone to read it, and again, staffing shortages is a huge factor.
And I think you want to jump in on that.
Yeah, I mean, again, I've been working as an advocate and you know, working in health technology now for 13 years. And the issue about literacy and, you know, patients don't understand data always kind of drives me crazy because, you know, you don't understand anything until you have access to it. And you don't understand anything until you have a need to understand it. So, you know, the analogy, like I bought a car during COVID. I live in downtown DC. I like to walk and Uber, but I, you know, took my first Uber in the midst of COVID and almost had an anxiety attack on the way to the doctor because of exposure potential. So I bought a car. I don't care about cars. I mean, I know what I like as long as it matches my outfit and, you know, but like, when you're spending that much money on a thing, you learn about it. You like find the like tech specs and you Google them and you figure it out because it's a substantial issue, it's a substantial purchase. Now, compared to my health, that's a relatively frivolous thing. When I first was diagnosed with diabetes, I didn't know anything about it. I vaguely knew that I was gonna have to take shots, but I didn't realize that the shots were the easy part. It's the management and the insulin that can kill you at a moment's notice that gets tricky. But like, I learned about diabetes when I was first diagnosed with retinopathy, and with kidney disease and neuropathy, same thing. You learn about it when you're exposed to it and when you're forced to learn about it. But if the data isn't there, if it's too difficult to access, if the problem that you're solving is getting access to the results as opposed to understanding the results and working with the results, that's where people get burnt out and frustrated. If they have readily accessed data over time, they understand it, they get a sense of where it is within the context of their broader life, and they're able to incorporate it into their understanding of how to manage their disease, what they need to do, how to interact with their doctor, how to ask better questions. But if you just give somebody data out of the blue with a brand new disease, they don't know anything about it, they're of course going to be overwhelmed. They're of course going to be flooded with emotion. But most people are smart enough to figure out what it takes to help them be healthy and survive and help their families be healthy and survive. The question is giving them access to the raw materials so that they can do that. And that's what the people in this room can help facilitate, is making that data more available, making it usable, making it exchangeable so that patients will be able to understand and have the context to be able to manage their disease.
Super. So I'm going to ask for some final closing thoughts from each of you, and then we'll open it up to questions from the room. Shamekka, any closing thoughts?
Just to sit with patients, take into consideration what we're going through. I'm a project manager, that is my day job in cybersecurity. And I feel as though I am project managing my life, and I have to because it's important to me. And when you think about it that way, you're like, oh my gosh, that is taking it. What is on the roadmap? I have all these symptoms. What is more pressing than the other? Let's put that on the roadmap. Let's do a deep dive into this, talk to your doctor about that. Think about it as a project because you're all healthcare professionals. And if we think about it that way, you can take it as, you know what, this is very important. Getting access, what can we tackle right now? We can't change the world in 5 days, but what can we do right now? What can we really focus on? And just learn from what we had to say in our patient group and from other perspectives, and hopefully that can help change the way that we're doing things moving forward.
So you would encourage everyone in the room to get on our website,
Yes.
click on that report, watch your video, and look at those reported findings to see how they can make a difference in that.
Yes, something tangible and you can refer back to.
Awesome. We like tangible. We like practical. That's what Mary Ann always says, practical solutions. Okay, Grace, how about you?
I keep thinking about an analogy that as I've been listening to all the conversations and even the proceedings and developments over the last year, and I think of a police department. Everyone has a local police department with a non-emergency line that they can call for information, to report a branch that has fallen, or whatever you need. But there's also 911. And I challenge everyone to think about IAS as we shape the future as 2 channels, 2 phone numbers. A local non-emergency line, and the house is burning down, call 911. And how do we start operationalizing and thinking about all the no, we're not going to answer, and yes, we have to find a way to answer. And I understand that there's compliance and fear around an improper disclosure, but I can assure you on the other side of that IAS request is an individual who is just as afraid because their loved one or their life is on the line. So we can't lose sight of that. How do we build a future that addresses the non-emergency and the emergency IAS use case?
Thank you. And Anna, last words before we open it up.
Last words. I guess I would just like to say I really hope to work with each of you guys through this work group, and I hope that many people will come to the table and choose to work with me and other members like Grace and Shamekka to really think through what can we do collaboratively to make this stuff work and to think about how can you use this work group and engaging with consumers as a mechanism for making things move in your organization, both for understanding the importance and the utility, as well as for generating the kind of excitement and possibility and understanding that will enable you to get through some of the barriers in your organizations to make this work. I think it's a great opportunity. We have a lot of great work to build off of from the Consumer Voices Workgroup, and I'm super excited about the direction that we can head together.
Thank you. Thank you. Okay, so any questions? Any questions for the panel? Don't be shy. Everybody's hungry. Oh, there's somebody over there.
Thank you for sharing, and what an impressive panel. I would say that generally I would speak for everyone in the room and say we are a bunch of doers ready to do this work. That we don't need any more motivation, though your stories are very inspiring and call to action. And so to do my part to bring some big energy to this, what I would suggest is that we can do a lot of work to build out the digital health infrastructure that's required to make data accessible. And I loved your point about patients don't care about access. They care about response. They care about how is this going to help me? What I would suggest is the business drivers, the business of healthcare is not aligned with what you're looking for and what we need to deliver on what you're looking for. And so if we could reframe all of the work and the energy that you are doing to really work with the policy to drive the business drivers that change clinical behavior to when you have access to it, do something with it. take the time. You are financially motivated to take the time to do something with it, because right now that doesn't exist. One of the complications of our industry is we can lead the horse to water but can't make him drink, right? So we can deliver all the data sources, all the information, but if they aren't incentivized properly financially, then it's meaningless. If it's 2 clicks deep, 7 clicks deep, I'm not taking the time to do that. It's the right thing to do, but if it's not in their workflow and they don't have the proper financial incentives, then we, this group, can never deliver on what you're asking us to deliver. So we should really work together to really focus in on that side of it, because it is a key point that I think is the fastest way to get what you're asking us to do.
Can I ask you to be specific about the they in this instance?
Medicare, Medicaid, payers. I mean, business, healthcare is a business, and they're going to make their choices about your care primarily based on what they're going to be paid for, whether it's managed care or fee-for-service. Fee-for-service still drives most of it. And so, yeah, are you in their referral networks? Are they going to benefit from that referral network? A lot of healthcare is still driven by the business. And so we have to just acknowledge that. It's not going to change. How do we work with it?
I think those are excellent points, but I have to point out that maybe what's missing is there are incentives. I think we're doing a terrible job of making the connection. Somehow IAS is siloed like a nice to have, and that's adorable, they'll go look at it. No, because if that patient gets those records, maybe they can get onboarded at that hospital and start treatment faster. If that patient gets their records, maybe they can sign up for that clinical trial, which is going to drive innovation and bring a trial to completion. If this patient gets their medical records, well, there's so many different possibilities. In the context of a business strategy, we don't want people to not make money. Clearly, this has to be sustainable. But to your point, maybe outlining what the ROI is for IAS in specific use cases and why it matters, that is something I think in collaboration with a patient focus group could easily, low-hanging fruit, be knocked out of the park. White paper done, 2 weeks, not even. I think actually if we sat at the bar tonight, we could probably get this out tomorrow. There's enough wisdom in this room to get that done. 7 o'clock. Monkey bar, 7 o'clock.
Great panel. Thank you all for putting it together. Just a couple of comments. First of all, I loved what you said about 911 and then the regular line. And I know for me personally, trying to be in this space and make it happen, I've been thinking about it too broadly, and how do we get patient access to everybody? How do we communicate and market and all those things? And what I'm going to take away from here is exactly what you pointed out, and that is we need to start small, right? And we need to start small with those folks that need to be in trials, the emergency department folks, the unconscious folks, the family that needs. I think if we stopped what we were doing and stopped worrying about how do we find those third parties or whatever that are going to have portals that we can all go get to or use Google Health, and focused on a solution for the critical need people, that the rest of it would come. And that's going to have to be something that gets given to them or to you, at the point of kind of the point of care, right? At the point you are there. The other thing I just want to make a comment about, and I think some of this work has been really paralyzed because of the patient identification, and one of you mentioned it, but I think that's one of the first things you've got to address is how can we put a process out there so that everybody's bought into the patient identification. It's never going to be perfect. But our legal system and all the people that want to sue people and all those kinds of things paralyze us with patient identification. And I think I know we have the patient identification fire resource ready to go, but knowing how to get it to the right person at the right time. If we could solve that, I think we would really accelerate the whole thing.
Hello, my name's Robin. I'm from Bay Health Medical Center in small Dover, Delaware. and happen to have 3 other people from Delaware here. It's very odd. I am not from the industry, so to speak. We are providers of healthcare on the front line, and I want to thank you for doing what we're all supposed to be doing, and that's putting the patient at the center and kind of making that the priority. So I thank you all for sharing your stories. I also am a type 1 diabetic with many health complications, so I'm here as a member of my organization and to help the state with interoperability, but also as a patient. So thank you very much.
Mark Newberger, I just want to make a comment expanding on what you just said, but with the 911 example, we all know 911. Doesn't matter where we go in the country. We know 911 when there's emergency. I'll bet almost no one in this room knows the local number. And what we need to focus on is the 911 instance, but we have to do that in advance of the 911, because if the system's not there, there's nobody to call. And so the IAS, I think, is actually the most important use case that everything else spins off of. Because if we're not taking care of the patient who is becoming the center of healthcare, how are we going to address anything else? Because nothing else really matters, because that's why we're all here, to take care of the patient. So I would be interested to know if at any point, especially from the examples that each of you gave, have you found that there's a certain point where the consumer is the expert?
Absolutely.
And at that point, how can they help us force the policy to address? Because that's what happened with 911. And then the financial aspect will fall right into place. I'm curious to what you think about that.
Expert about what? About the technology? About their disease?
Well, they all become experts on their disease if they live long enough, right? But it's really when they have to not only take care of themselves, but when they have to take care of a child or an aging parent. And that's a significant portion of the population. So they have to manage the data between all the various providers, because almost no one has a single provider, right? Even if they're within a single health system, it's so dispersed due to M&A that happens within those health systems that you're still dealing with, on average 5 to 7 different access points, whether it's the lab, the imaging center, the doctor, the patient portal, the pharmaceutical, the pharmacy, or even the other healthcare providers besides physicians and hospitals. So I'm just curious as to at what point did you all feel that you became expert? You started as a child, you started as an adult.
I mean, I spend a lot of time dealing with this stuff. I don't know if I would consider myself an expert in patient portaling. I mean, I had a doctor's appointment earlier this year. I'd had, an issue where I'd had 3 different doctors do labs on this particular thing. And I spent an hour with the 4th doctor going from one portal to another to try to find the right value that I needed, the right reading. And finally I was like, well, I think it was X. I mean, does that make me an expert? I don't know. But I mean, there's a lot of us that have been forced, very much against our will and personal desire, to become expert in attempting to navigate it. I mean, the issue is that the kind of expertise you need, because frustration is substantial. I mean, for me, I helped start a patient hacker movement. I was one of the early founders of a patient hacker movement, where with diabetes devices, we were like, screw the device manufacturers, FDA, et cetera. We're hacking into these devices to be able to get them to do the things that we need to do to keep ourselves and our kids healthy. And we've done that, and it's worked incredibly well. And it's honestly saved lives and improved lives dramatically. So there are different types of expertise that we can bring to the table. I don't know that I'm one to suggest everybody starts hacking into their hospital system's medical records. I don't really think that would be the way to go, but
We do have a suggestion, though, and that is Anybody here in this room that's interested in taking this journey with us, please go to our website, register for our Consumer Engagement Strategy Work Group, where we will start where Shamekka and Grace left off, and you can help us write this the next future. I know there's a couple more questions, but I'm being told to wrap up. So check with anybody on the panel if you have a question, and thank you so much. Enjoy lunch.